Friends, welcome to the education and awareness sessions conducted by the PACE Hospital, Madhapur. I am Dr. Ramesh Parimi, Senior Oncologist of this hospital. In the past also I have interacted with you about some of the basic things in oncology for the benefit of all of you, to create an awareness among you about oncology, the genesis and the disease process and the treatment protocols. Today, on public demand, I would like to share some things about what is called chemotherapy. Well, a lot of friends have asked about this, and the people who come to me also as patients and their attenders, they have a lot of doubts and apprehension about chemotherapy. Now, let us discuss some of the basic things about chemotherapy so that you would understand in the science of oncology the role of chemotherapy. Chemotherapy is a form of treatment, is a type of treatment. Chemo means chemicals, it is related to pharmacology, that is pharmaceuticals. The drugs and medications which are given to cancer patients consist of what is called chemotherapy. Chemotherapy can be in the form of injectables, oral tablets, or even subcutaneous injections, and at times it is what is called through the port. So, chemotherapy is a form of treatment for cancer, and it can be given in any stage. Not that chemotherapy is given only in a particular stage of the disease, no. Chemotherapy is given sometimes even in the first stage, that is early stage of the disease, and also at times in the late stage of the disease, that is stage 4 cancer. Chemotherapy per se, as I told you, is the administration of anti-cancer drugs intravenously most of the times, and this chemotherapy is given for almost all type of cancers, including solid tumors and liquid cancers like leukemias, lymphomas. So, regarding the types of chemotherapy, as I said, the drugs could be three-way administered. It is not the question of administration, but it is a question of what you call different type of molecules. That's what is meant by the types of chemotherapy. The molecules can be in the form of antibiotics or antimetabolites, the age-old traditional drugs. Of late, we have also got what is called molecular genetics, and the micromolecules are targeted here, where in the target therapy, the biological factors intracellular or within the cancer cell which affect the progress of the disease are targeted. Either they are blocked, or the particles which encourage and support the cancer cell growth are mimicked. This is called agonists. So, the conventional chemotherapy apart, like anti-cancer antibiotics, metabolites, we have also called what is called monoclonal antibodies. These biological molecules are nothing but monoclonal antibodies. Antibodies developed against particular antigens expressed on the cell membrane of the cancer cell. And in the progress of this also evolve what is called TKI molecules. These are all mainly oral, while the monoclonal antibodies, that is MAPs, which are about 98% of the times used in cancer therapy, are all intravenous preparations, and in certain situations they are also used in non-malignant conditions. So, chemotherapy is also used in non-malignant conditions, sometimes like rheumatoid arthritis and other diseases, wherein not only oral form of chemotherapy, but also injectable monoclonal antibodies are given. The latest example being what is called ulcerative colitis. So, chemotherapy as a form of treatment in the majority of the situations is for cancer. In a minor setup, it is also used in non-malignant conditions, as I have enumerated. So, this is in brief about the introduction for chemotherapy. Almost all cancers do need chemotherapy, because the aim of cancer treatment is to eradicate the disease completely, to extirpate the tumor, and also to give a cure for the patient. In this setup, the approach to a cancer patient in the form of treatment is multidisciplinary, otherwise called multimodality. Multidisciplinary means different type of doctors sit together and evaluate the patient, stage the disease, and pronounce the line of treatment. This type of body is called a tumor board, which is present in every cancer treatment center. The tumor board consists of, as I said, multidisciplinary team of surgical oncologists, radiation oncologists, and medical oncologists. There are also other physicians who play a vital role, including pulmonologists and intensivists, in the treatment process in due course of time. Now, having formulated the line of treatment, a disease, cancer disease, can be treated only by one modality of treatment, that is called either only radiotherapy, only surgery, or only chemotherapy, or it can be multi-modality treatment involving multidisciplinary team, like combination of and permutations of these three modalities: surgery, radiotherapy, and chemotherapy. In this situation, it should be remembered that chemotherapy can be given as an adjuvant or neoadjuvant, that is, before doing the main line of treatment. For example, for breast cancer, the main line of treatment is surgery, either mastectomy or breast conservation surgery. With respect to the surgery, sometimes we do give chemotherapy to the patient before starting the main line of treatment, which is surgery. Sometimes there is radiotherapy is given as a line of treatment, but before radiotherapy, chemotherapy also can be given. Similarly, after surgery also, chemotherapy can be given in various cancers, including breast cancer. So, chemotherapy given as a whole before starting the definitive line of treatment for a particular cancer, or it can be combined with cancer surgery or radiotherapy given after the definitive line of treatment, surgery or radiotherapy, that is called adjuvant setup. So, chemotherapy given before and or after the main line of treatment, which can be surgery, which can be radiotherapy in that particular case. Having said that, it should be remembered that chemotherapy can be given in the early stage of disease also. When the cure rates are pretty high, we do not take any chance or leave no stone unturned. Surgery can not be possible to extirpate the tumor completely, especially solid tumor, because of the locally advanced disease. In that setup also, to downstage the disease, chemotherapy is given in a neoadjuvant setup. Appropriate drugs are used in appropriate setup, and following that, downstaging disease being done, surgery is done to eradicate the disease completely and achieve better cure rates or long-term survival rates. So, it can be alone or it can be in combination with radiotherapy and surgery. Now, when is it given alone? For example, in leukemia, blood cancers, and lymphomas, see, the main line of treatment is chemotherapy, so which consists of various conventional chemotherapy drugs and also biological molecules. So, these are the tumors where they are spread various parts of the body and extensive in distribution. So, surgery is out of question, and radiotherapy is also not generally advocated at the outset. So, these tumors where the dissemination is very much, including solid tumor like breast cancer or colonic cancer, where stage 3 or stage 4, when the disease is spread to the lungs, bone, brain, or multiple sites, and surgery is not feasible, radiotherapy cannot be given to the various spots affected. Chemotherapy is the only choice. When the disease is extensive and stage is higher, the chemotherapy aim is only palliative. So, neoadjuvant, adjuvant I talked, which is a definite line of treatment, and the intention is probably downstaging and also curative. Now comes what is called palliative, where definite line of treatment is the surgery. Radiotherapy is not going to help the patient, and the disease is extensive, multiple organs are involved, multiple sites in the body are involved, in which case chemotherapy is given as a case of palliation. When you give the drug through the vein into the blood, it goes into various parts of the body wherever the cancer is disseminated, and these drugs effectively arrest the progress of the disease to a great extent. Cure may not be achieved, but palliation. Palliation means relief, relief from pain, relief from other symptoms like breathlessness in lung cancer would be achieved to some extent or to a major extent by using the palliative chemotherapy. These are the various situations where chemotherapy is used all alone or in combination with different line of treatment, either before or after the definitive line of treatment. chemotherapeutic agents, as I told you, they target the cancer cells, and these drugs have an affinity for that. They enter the normal cells also, but mostly taken up by the malignant cells, and they are cytocidal. That means they kill the cancer cells. That is one. Secondly, they also prevent the multiplication of the cancer cells. So that is hyperplasia. The cancer cell will not divide further, and that is the end of the cell cycle, and the attrition occurs. The cell attrition occurs. So these are the various types of modalities by which the chemotherapy agents work on the cancer cells. Yeah, when there are good effects of chemotherapy, there are also side effects, obviously, and the side effects can be mild, moderate, or severe. The mild symptoms or side effects being, sickness, nausea, and then vomiting. This is mild. Sometimes irritability or burning sensation in the mouth, that is called mucositis because of chemotherapeutic agents, and dryness of the mouth. There is also what is called alopecia, or temporary loss of hair. So these are the common side effects you find, but the major problem is what is called uh, diminution of blood formation, and in medical language it is said myelosuppression. So the bone marrow, where in adults, where the blood is formed, various elements of the blood, including the red blood corpuscles and white blood corpuscles, platelets are formed. These are the main components of the blood. The bone marrow is suppressed. When there is suppression of bone marrow, the blood counts fall, including the RBC count, white cell blood count, and the hemoglobin. Because myelosuppression is one of the major side effects, and that's why before giving chemotherapy, which is generally given in cycles with a gap of about 3 weeks average between one cycle and the other, the bone marrow takes time to replenish. So the observations over a period of time by various scientists centuries down have formulated that the gap should be around 21 days, wherein the myelosuppression effect, serious side effect of the chemotherapy is overcome by the body, and blood counts are brought to near normal level, including white cell counts and RBC and hemoglobin. So that's why 3 weeks gap is generally advised. Like in radiotherapy, 5 days in a week is given, 2 days the rest is given, so that the body recoups the original energy and also the blood counts and others. This is the rationale behind giving chemotherapy in cycles. One cycle means it can be one drug or multiple drugs. It can be 1 day or more than 1 day. It can be 3 days sometimes. So depending on the various combination of drugs and the disease stage and diagnosis, the chemotherapy agents are given in different proportions over a period of time, and each cycle once ends is given a gap of 3 weeks generally. Sometimes the chemotherapy is also given in small doses, day 1, day 8, and day 15, like that. It all depends on the stage of the disease, and also importantly the performance status of the patient. Performance status means the normal physical and mental activity, especially physical activity of the patient, who is not debilitated, who is not weak, whose counts are regular, who is able to ambulate himself more than 12 hours in a day. Depending on all these factors, the performance status is gauged, either stage 1 to 5 like a COX, or 1% to 100% like in WHO scale. Depending on the performance status and the situation and stage of the disease, the chemotherapy is advocated. Which I already told, and just to recapitulate, it is the various chemicals, that is the molecules, pharmacotherapeutic molecules, or monoclonal antibodies, or even TKI molecules, which can be orally given. There is also what is called offshoot of chemotherapy called immunotherapy. As you all may be aware that immunity is a kind of resistance of the body to resist the infection. Two people may live in the same environment, but one may get affected by flu or other respiratory infection, but the other doesn't. Two smokers may be there, but their resistance to infections of the lung may be different. That's what is called immunity. Now, this immunotherapy is one form of chemotherapy, roughly speaking, which would help the body to boost its own immunity and then combat the cancer cells. The checkpoints are blocked of processing and the cancer cells are deprived of further multiplication. So immunotherapy is the latest in the paraphernalia and the feather in the cap of the chemotherapies and chemotherapy, wherein body's immune mechanisms are boosted up by using appropriate agonists and blocking agents. Whichever these factors in the body are helping the cancer cell to thrive, those factors are identified, isolated and blocked by giving from externally these therapeutic agents called immunotherapy agents. See, there is no hard and fast rule. Chemotherapy given as long as needed. The need based it is, and also the need differs from patient to patient and the tumor burden. Having said that, it can be given generally 6 cycles, 3 cycles, or say 4 cycles before the definitive treatment is given, another 4 cycles after the treatment is given, irrespective of the duration, either day 1, day 8, day 15, or once in 3 weeks. So it is not a hard and fast rule. Sometimes we keep on giving chemotherapy where surgery is not possible, for example in a solid tumor of colon or breast, till the patient tolerates it or disease progression is achieved. As long as there is a disease progression achieved and arrested, patient is able to tolerate it. The chemotherapy given even in a palliative setup up to number of times. So the dose and number of times depends on the stage of the disease, response of the body and the tumor to chemotherapy, and other factors as I said, performance status and tolerability and well-being achieved, the quality of life being achieved in a palliative setup. Having said the side effects, they themselves cause some discomfort and inconvenience and also a kind of sick feeling in the patient. And apart from the side effects, the chemotherapy is not going to harm the patient provided we take care, the clinicians take care to limit the side effects of it. That's why nowadays before giving the main chemotherapy regimen, some system is loaded, the blood of the patient is loaded with some supportive care elements. These are called antiemetics, which will prevent nausea and sickness, and also some injections which are called colony stimulating factors following the chemotherapy given day 1, 24 to 48 hours later, periodically either 1 or 2 injections generally, to improve the the blood counts. Having understood that myelosuppression is a serious side effect, these colony stimulating factors are given into the injectable form into the subcutaneous tissues to boost the blood counts. Blood formation is augmented. As you all might be aware, radiotherapy is high energy rays, like Roentgen rays were invented by Madame Curie. Later on came different isotopes and also the high energy releasing particles and matter. So the particulate rays which are derived from the source of radiation, like linear accelerator nowadays. Previously we used to have that cobalt 60 therapy, wherein high energy rays are produced and liberated from the cobalt, the isomer, and they are focused on the tissues where the tumor is present, and that used to extirpate the tumor. There were also side effects of that cobalt therapy, now which is almost getting into oblivion and outdated. We are using nowadays mostly all over the globe the linear accelerator, wherein the energy rays are artificially synthesized and produced and projected onto the tumor tissue. And as a recourse and development to the linear accelerator, there are various improvised gadgets have come, including tumor assisted or tumor directed high energy rays, that is called IMRT, that is intense modulated radiotherapy, IGRT, image guided radiotherapy. So many. And you might have heard of what is called rapid arc, which came into existence about 20 years back. It is a the dose enhanced and the time decreased form of radiotherapy, that is called rapid arc. And also the side effects of these improved gadgets like IMRT is very minimal, because the focus is on the tumor site only. The surrounding normal tissue is not affected much or very minimally affected, so that the bad effects of radiation are minimized. So this is radiotherapy, wherein as an outpatient the patient goes there after the simulation and treatment planning system and all that. The energy rays are given appropriately, and as the tumor diminishes over a period of time, that is called grating, the focus is also reduced. The area of focus of the radiotherapy is reduced, so that normal tissue is not affected. So that is what is called the image guided radiotherapy gadgets. All these newer gadgets, including true beam, help to minimize the side effects of the radiation on the surrounding normal tissue, and also improve the tumor ablation precisely and specifically, so that the patient feels all the time near normal even while undergoing radiotherapy. This is the main difference, whereas this is no touch technique rather. Of course, there is also, apart from the external beam radiotherapy, there is what is called the intracavity radiotherapy, which is given using an isotope into the cavity. For example, cervical cancers, there into the vagina it's kept the radioactive, that is what is called intracavity radiation. So there are different types of radiotherapy, which is a gadget oriented and a kind of outpatient procedures, whereas chemotherapy is always hospitalized either for a day or 3, depending on the protocol, and strictly under supervision of the medical oncologist and his team. Supportive care, the chemotherapy is administered. Radiation oncologists do a lot of physics and also the mapping of the tumor by arranging the topography of the tumor. The rays are direct. As long as oral therapy is not there, there is not much of interaction of the chemotherapy agents with the food. Of course, there are some TK molecules which are got food and drug reactivity, and the patient is cautioned about it. Otherwise, intravenous chemotherapy does not have much of food interaction, but after chemotherapy the patient is advised eat always freshly prepared food, not to eat stale food or canned and tinned and frozen foods, because infection rate may be high, including gastroenteritis. As the immunity will be low following chemotherapy and the blood counts are low, these patients are prone for infections, intercurrent infection. That's why they are guarded about these intercurrent infections by following some precautions. Food, always take home cooked, freshly made food and hot food rather. Secondly, a lot of vegetables and green salads fresh are advised. Keep the diet light and very balanced. Outside food is not encouraged. Similarly, going to crowded places, one may get infected because of flu and other virus. He is advised not to go to crowded places, and also if necessary to go outside, put on a mask or cover himself well, so that the dust and pollen and the infection would not enter through the nose into the respiratory tract, and they won't develop respiratory infections and pneumonia. So gastrointestinal infections have to be safeguarded against, respiratory infections have to be safeguarded against, and any other onlookers, I mean family members or friends who come to spend time with the cancer patients are also advised to maintain a distance and avoid the visit if they themselves are suffering from any upper respiratory infection or otherwise. There are some of the precautions to be observed by chemotherapy patients following the chemotherapy, and as long as the chemotherapy session is on, it may be in cycles over a period of 6 months. Safe precautions are always advised. So, my dear friends, I have covered as many aspects of chemotherapy and doubts expressed by my patients and their relatives. Hope it has been very useful to you. And one need not be very apprehensive and scared about chemotherapy. No doubt it has got some side effects, but it's never painful. And there are medications nowadays in improvised chemotherapy setup to give to preempt and prevent these side effects, when it is necessary, we should not go back on the pretext of either apprehensive or side effects, and should go for the treatment with full confidence under the able guidance supervision of a trained and experienced medical oncologist. Anytime you are welcome to call me at the Pace Hospital for any doubts regarding the chemotherapy